for the session.
Thank you. Welcome everyone, and I would like to thank the organizers for inviting us to chair the session. It's my pleasure to chair this session with Professor Mohan Isaac, who was the professor and head when I was a senior resident in NIMHANS, Bangalore. It is my pleasure to introduce Dr. Manoj Kumar, who is the founder and clinical director of MHAT, the Mental Health Action Trust, which is a community mental health care and social care organization. Professor Dr. Manoj asked me not to detail all his awards and previous fellowships and all that, so I won't do that, but I thought the slide was going to be here. Professor Murthy, since the slide is not there, I'll just say that Dr. Manoj Kumar got B.S. Chavan Memorial Award in 2025, the Kerala TV Best Doctor Award in 2023, Ashoka Fellow in 2017, and lots of other awards. Professor Murthy yesterday talked about social determinants of mental health from evidence to action, and this talk by Dr. Manoj Kumar will be a radiant example of exactly that, how social determinants of mental health can be incorporated into provision of mental health care delivery.
Okay. Before I invite Manoj to come up on the stage and deliver his presentation, you can actually come up and as I take few minutes to introduce you further. It's a great pleasure for me to introduce Manoj for a variety of reasons, and I'll tell you just one or two reasons. I decided to work in the field of community mental health at NIMHANS in 1976 when the Sakalwara Center was started under Dr. Kapoor. At that time, there were very few people working in the field of community mental health in India. Not that the number of people working predominantly in community mental health in India has increased tremendously. It is still only a handful. And since there are people who have chosen to work in the field of community mental health, taking evidence to action, I have been personally interested in learning the trajectory of those people. Why would a very successful consultant psychiatrist trained in the best of the institutions in India, working in Leeds, UK, come back to India? Many people, of course, working in UK as consultants come back to India and, of course, settle down in good practice, etc. Why would somebody working in Leeds come back and plunge into community mental health, taking evidence into action? That is what Manoj did, I think in 2006 or 2008. So I've been personally interested what drives people to do these things. I know that there are 2 or 3 reasons. I may be correct or wrong. These are from conversations with him. I think one of the personal reasons was his passing of his mother around that time. Second was a tremendous influence that his father had on him when I understand his father was a judge, and his appreciation of the sense of justice and commitment to the society, etc., influenced him. And thirdly, I don't know, Manoj, my co-chair, referred to Dr. Murthy's presentation yesterday. I wish to refer to Roy's presentation. He showed a slide about the palliative care model, which he incidentally in his talk said it's probably one of the best and one of the very few such models occurring in Calicut districts in Kerala. I have seen it myself, I endorse that. So Manoj was also influenced by the community palliative care model, delivering excellent palliative care to very marginalized people who cannot go to the best of the institutions, which is still ongoing, and there is an Institute of Palliative Medicine in Calicut, etc. He was influenced by that, and he started the MHAT, Mental Health Action Trust. Of course, he is going to talk to us about it. It has become, starting in one center, in Wayanad, Malappuram district, Wayanad and Kozhikode, which I had the privilege to see during its initial stages in 2011-12 or so. Now it is there in so many centers, maybe about 100 centers in Kerala and rest of the country, including Bangalore, because I met him in Bangalore. He is setting up some of those similar kind of program. So this is his life, this is his work. It's a community mental health care delivery model. I have also read that it is referred to as Samagram. It's a Sanskrit word. I would leave it to Manoj. It's my great pleasure to introduce and request Manoj to deliver his talk. Back over to you, Manoj.
Thank you very much. A lot of, my task has been made easier by the very kind introduction. But first of all, a big thank you for providing me with this opportunity to talk about our work. Thanks specifically to Professor Basu. And we have had the good fortune to work together in a very interesting situation. So yes, thank you for this opportunity. Now, as one of the chairpersons said, this is not about the theory of social determinants. We have had excellent presentations detailing the evolution of the concepts of social determinants and all the theoretical aspects. So this is about what we do in the field in making that reality come true. So essentially what we are doing is to try to integrate social determinants or action about social determinants into what we aim for as a comprehensive mental health program. And it is, because we work in the field, we have to be precise about what we mean. So both about community psychiatry as well as social determinants, when I speak about them, this is what I mean. In terms of community psychiatry, there are various ways of providing psychiatric care in the community. Most of the time it is based on the locality of presentation, which is away from hospitals and traditional clinics, closer to where people live and closer to their homes. But for us, community psychiatry is a much broader construct, which has both aspects of how we deliver it, as well as how we view it. For example, it's not just about shifting the location to the community, but it is entirely rooted in the local community. It is, so to say, owned by the local community. That's what we would like to see it as, which brings in with it tremendous advantages, because there is usually a local network of volunteers. So the relationship with the individuals and their families are at a different level altogether. Families, other agents of the society are involved. And because we work through local partnerships, and because these are long-term engagements, so the effect is cumulative. For example, if we add, if we can do something about a particular social determinant, then that act itself improves everything, improves the relationship, improves knowledge about mental health, reduction of stigma, and so on. So the methods of service delivery as well as the aims are different when we talk about community psychiatry. And when we talk of social determinants of health, the history has been well presented by multiple people, and we also follow the same kind of historical, we accept the same historical antecedents. Particularly, Dr. Mohan Isaac mentioned the word justice. Social justice is at the core of it. And that has, in history, come about because of industrialization and the increasing awareness of how the environment, whether it is at work or the larger environment, affects our health, and in turn, mental health. So we share the same philosophy. But when we try to do something at the grassroots level, we have to make some distinctions. For example, we can only try to address what we can address locally in the immediate environment that are amenable to action. Other things which in the broader theory of social determinants might come under social determinants are things which are powerless to act. Either causes of intrapsychic trauma, which are deeply rooted in the childhood experiences and so on. We can only try to address it in the common biopsychosocial model after the event has happened. And much wider factors, including climate change, which is increasingly a focus of our work, again, are much more for research, policymakers, and for advocates. But we focus on the immediate environment of the client and the family, and what we can try to do to ameliorate that. So these are the usual areas that we try to focus on. Always the starting point is economic stability, moving on to education, the whole context of social support and community engagement, access to good quality care, not just mental, but local physical care also. And we try to focus on the built environments, houses, toilets, sanitation, things like that. So far, I mean, again, early on in my training, even though I was exposed to Nimhans and Sakalwara and so on, for most of my initial career, it just remained a theoretical aspect of mental health. While we focused on the biological aspects, this remained kind of distant, not directly involving us, not touching our lives. And even after I ventured into community mental health care, the social aspects, the social psychiatry, social determinants, I initially thought was something that we as psychiatrists or we as mental health professionals are unable to influence, or it is not our job to do it. It's for the governments, it's for international agencies like WHO, governments, and so on. And because we have always worked in the healthcare system, not in the social care system. Even in countries like the UK, where social care is very good, these are kind of parallel systems. So we don't have the expertise of being in contact with the local realities. How many of us have ever visited a village panchayat office? We don't need to. We don't even know how these things work. How many of us have seen how so ASHA workers work? These are people that we consider outside of our system, that we always talk of using them, while we provide good biological care. So it wasn't touching my life also until a few years ago we realized that while we are trying our best to provide mental health care, it is kind of a bit too late. It is after many pathways have come together to make the mental illnesses happen, then we are trying to intervene and do something about it. So the idea struck that maybe a comprehensive model, which we call Samagram, it becomes comprehensive only if we also start addressing social determinants. And that was a big leap for us. So I then began to believe that as psychiatrists, as most of us here are probably, we can play an active role. However, this means that we have to redefine our roles. In the previous presentation, it was mentioned that we should be agents of social change. That is absolutely correct. We are right now, I think we are, all our immense capabilities, we are focusing on a very narrow field of personally delivered psychiatric care. Of course, we lead teams and so on, but we can do much more for societal change while retaining our focus as practicing psychiatrists. That is what I believe in. So I would like to submit 3 or 4 things. The first is what I just said. We need to, rather than expect the government or expect someone else to address social determinants of mental health, we should consider it as our integral roles to do the same. Again, unless care is delivered in a local community setting, I would like to submit that we cannot really address social determinants because we would have no agency there. But if you are involved at the community level in providing mental health care, then we automatically become empowered to do something about it. Dare I say, it may even be possible to attempt primary prevention if we target entire communities, so that the genesis of mental disorders become less. That is the true sense of the primary prevention. We have limited experience with that, at least in one tribal area. It's very, very difficult to address the social determinants in an entire population rather than focusing on just the clients and families that come to us. And lastly, if we have to provide good quality comprehensive care, I submit that we must address social determinants. So what is good quality care? Often, even though no one says that, going by the prevailing models, we tend to believe that good quality care may not be possible in the community care setting, so we do what we can, essentially provision of medicines at locations close to people, where people live. But it is possible to provide good quality community mental health care, provided that some of the assumptions that we make, particularly the assumption that only psychiatrists can provide good care, while we have plenty of evidence that task sharing and involvement of other mental health professionals, they can do sometimes an even better job than we can. But we are not used to thinking in those terms, and perhaps we even feel threatened when we think that others can do a better job in delivering mental health care. So we try to provide a voluntary, in the voluntary sector, a free service to the economically dispossessed people, which is entirely free at the point of delivery. And we try to make it good, comprehensive and good care. And the crux is that the focus is on long-term care. So many of the other elements become important, such as the use of databases and telepsychiatry become important because the focus is on preventing relapses and providing long-term care. So good quality care is what care that we all would like to receive would look like. Care delivered with a sense of equality and respect, with adequate time provided, people being seen on time, people being given appointments, detailed assessment and focus on reaching the correct diagnosis, good pharmacological practices which always translate to use of fewer medications, not the latest medications, and so on. We have the luxury that we can follow people almost 24/7 because of our systems. So we don't need to over-medicate people. We can afford to under-medicate them and then gradually titrate up. Assertive outreach or proactive follow-up is again one of the key elements. And of course, attention to physical health. And attention to continuous care through follow-up mechanisms, which is proactive. If someone doesn't come to the clinic when they are expected to come, a volunteer would make contact and find out why they haven't come. Databases, the importance of databases in this era need not be stated. And importantly, we have rich evidence from many studies pioneered by Professor Vikram Patel and all the rest of the people, that lay mental health workers can deliver psychosocial interventions. We try to provide community-based rehabilitation. We have daycare centers in many of our clinics, not all the clinics. And finally, as I said, we have reached the point where we are trying to attend to social determinants as well. Of course, it all depends on availability of resources, and also a lot of other factors, so that psychosocial interventions can be provided in the community. Peer and family support groups are there, daycare settings are there. Currently, we are in over 123 places in India. About 60% of the clinics, around 80 or so, are in Kerala. We have made the latest place where we have made a start is in Bihar, in the Gaya district, which has been an entirely different experience to working in the south. We are in the urban primary health centers, about 25 centers in Bangalore slums. At any point in time, we are looking after around 6,000 people in the way that I mentioned, comprehensively and with active follow-up. Now, how it works is because of the decentralization, involvement of volunteers, outside of the organization and lay mental health workers within the organization. A lot of, most of the care is delivered through task sharing. That doesn't minimize the role of the psychiatrist or medical interventions, but it's how we do it, through remote working, through telepsychiatry, and so on. This is the single point that we get most of the opposition from, is that? Okay. Most of the, if at all any opposition we get, that is about this single point of task sharing. Is it safe? Can others be trusted with many of the aspects of the care delivery? Technology comes into it quite a lot, databases and telepsychiatry, and a truly multidisciplinary team. We have, apart from me, 6 other psychiatrists working, some of them part-time. We have quite a lot of senior psychiatric social workers, senior clinical psychologists, and as I said, there is occupational therapy, Department of Sociology, which I'll come to, and most importantly, lay mental health workers. We all work together without turf issues or anything. So we set up a social development team to spearhead this work about 3 years ago. It is headed by a colleague of mine, Dr. Meena, to whom I owe many of the facts being presented and the pictures. So her background was working in the social development sector, and then she came to us because she was convinced that unless mental health issues are dealt with, focusing on social determinants alone does not work. So it is the kind of complementary view of someone who had worked in that setting and come up against the stumbling block of mental disorders. So the social development team plays 2 roles. Where the individual staff members are located, they take an active part in the actual delivery of social care. Mind you, we do not have a big enough team to cover all our clinics, particularly outside of Kerala. So the team also supervises others in the team in places where they are not located to do the same things that they are trying to do. So we need to have a good awareness of government policies, because most of the work, or a lot of the work, is in accessing these schemes which are already existing. And our client group are singularly left out of most schemes because of their mental health issues. So the methodology that the team follows is that nowadays, even the location or the starting of a clinic is dependent on the local support and locations where we can do active social determinant attention to. Strong partnerships right from the beginning are important. So we try to find local partners who share the same vision, and we position ourselves as providers of the mental health care, and we use their strengths, their rootedness in the community to provide joint care. So that applies for identification of clients and also actual house visits and surveys and group discussions. And then individual plans are made for the people who are our recipients of our care, starting with documentation of their needs and documentation of their entitlements. So we find that where we are active, and I stress again, this is mostly in Kerala, we find that at the beginning, about 50%, half of our clients are not able to access rightful entitlements. We have had situations where people have had not even any kind of ID, and it is, you can imagine how difficult it is to get into the system because these people do not exist. So we have to convince someone that this person exists in this locality, and then go on to find an address, phone number, Aadhaar card, and so on. So the entitlement gap not only extends to clients, but also their families. So wherever we have started this work about 2-3 years ago, we are happy that in those who we identified such needs, we have 100%, nearly 100% completion in availing the entitlements. Now that's not as simple as it sounds. It will entail multiple visits to local organizations, persuading the bureaucracy to particularly the UDID people, to recognize disability pensions to be, for people to qualify for that. It requires a lot of persuasion, a lot of work, multiple visits to the client and family and local institutions. So very briefly, just to illustrate the point, now this person was a 43-year-old person living with his mother, who was visually impaired, in a rehabilitation housing project. It was a tsunami-affected area, so that they were in a rehabilitation, already a project which was part of the tsunami rehabilitation, and receiving no entitlements. So that single intervention, made such a significant difference, particularly to the mother, because, as across social strata, the concern of the parents is what will happen after we go, when it comes to their children. So just the single fact that there was the possibility of this person receiving entitlements itself helped her to deal with the situation much better. Food and provisions is another area. Often we have to support people with daily food, rations or cooked food. So again, all this can be done. We can't do it ourselves. So we have to empower our local partners to, first of all, identify that there is a problem in such and such a household, and then work out solutions with them, depending on whether people can cook or family members can cook. So again, the expenses are met by the local people, by charitable bodies, and so on. And that is not just in Kerala. It happens in other places also. Housing and sanitation. These are, again, it all goes together, the social determinants. So first of all, we try to identify who are homeless through the baseline survey that all clients get in terms of social determinants. People living in ramshackle, dilapidated houses. And then we try to get others involved in building the houses, building toilets, and so on. But we have been increasingly been forced to focus on victims of climate change, so to say, in two populations, in the tribal areas as well as in the coastal areas. And in the coastal areas, the impact of climate change is much more harsh. Communities on the brink of displacement and lost livelihoods. So these are all what we are doing. But as I said, we can even think of primary prevention by working with communities. Another case study, where all the elements of what we do have kind of come together, is a family with 3 sisters. 2 are our clients. But the younger sister had stopped going to school for various reasons. So providing educational support to her was the start of the involvement, so that she could get back into school. Once the clients began to have better symptom control, the mother could start working as a housemaid. Disability pensions were looked into. Housing was looked into. Again, each of these interventions require a lot of running around. So it turned out that their house fell in the coastal regulatory zone, ZRS, which is a big issue in Kerala because we have a long coastline. So however, we were able to sort it out. And then the Life Mission, which is the body in Kerala tasked by the government with providing houses, they did part of the work, but it is only basic. So we had to get other people involved so that the house could be constructed properly. So quality of life improved, and their whole life has uplifted. We also have larger plans for housing, linking with architectural institutions and engineering colleges, so that they can provide support to our clients. These are the realities of coastal life. Flooding is common. People live in these kind of situations. But with intervention, small but safe and decent housing can be provided. Construction of toilets, again, another example. And then, we move on to livelihood. There often the priority is for caregivers for obvious reasons because they are more able-bodied and able-minded. About a third of our caregivers are in need of employment. Again, we try to reach out through local partners. Unlike other sister organizations where direct transfer is done, we have not resorted to that, mainly because of lack of resources. And throughout these community partnerships, I cannot overemphasize the importance of, because we become really part of the families and part of the communities because everyone is working together. And that in turn contributes to increasing the awareness and reduction of stigma in a naturalistic way. We meet with the local representatives, ASHA workers, and so on. Local members of the panchayat are, at least in Kerala, very active and very supportive. So we utilize them. And we are also aware of the challenges and criticisms of the social developmental model. I won't go into each of that in detail and answer, but we should be aware of these. Like in previous presentations, the dichotomy of critical psychiatry and biological psychiatry is totally meaningless. So we do provide medications in a holistic biopsychosocial model. But at the same time, we are very cognizant of the cultural aspects and the social developmental aspects. So I will end with these are the people who do the actual work. I do the talking. So I am grateful to my colleagues. We are funded by 3 philanthropies. We are thankful to them also. And thank you all for patient listening.
Thank you. Thank you, Dr. Manoj, for that excellent, short and crisp and very powerful presentation of your great work. The floor is now open for questions.
Hello. Yeah. It's a very inspiring lecture, sir. And I am Abhishek. I work here as an additional professor. And thank you very much, first of all, for enlightening us. The 2 points that was very striking to me in the program that you and your team have conceived. The first thing about your focus on the social equity. You have addressed the most marginalized population. You have tried to address the climate change, and which, bring home the point again and again that how social equity is so important, and how we should base our program and thinking, to be able to reach out to the last man stand, last person stand. So, the second thing which struck me is that your program is totally aligned with the Sustainable Development Goals, and that is quite fascinating. The way we conceive and our medical at present we are doing a National Health Research Priority Project, which supposedly kind of give a roadmap to the National Mental Health Program 2.0 by doing kind of a similar things that we do, but not focusing on the entire sustainable development group, but just focusing on the village level health workers, frontline workers, as they put it, task sharing, and then. But when we are doing this advisory group with the frontline health workers, what things that come up, what you have exactly pointed out, the problem is not that people suffer from depression, but the problem is poverty. The problem is loneliness in Punjab. The site I work with, it's Mohali district in Punjab, because there's a lot of old people who suffer from loneliness. Now our program cannot address loneliness. Fortunately, this is an implementation trial that we are doing. So we can, as we go along, we can learn and modify the program. But you have given us, at least for me, a vision that how sustainable development goals can be integrated within a mental health program. And up until now, I was taking a very narrow vision, and you have helped me to widen the vision. And so I just wanted to thank you for that. And
Thank you for that comment, Dr. Abhishek, and that reflection. We have a question here, and then
I'm Madhukar Katiyar from Kanpur, and we share the same initials, MK. Extremely provocative work, deserve a Padam Shri for you. In Kerala, you have 100 centers. Kindly come up to the north and UP, Bihar, Himachal, and East. You mentioned in being powerless in some cases, such as childhood adverse. You aren't powerless. You can work through them and do some palliation over working through. And you basically took a bottoms-up approach, and you can include a top-down approach and reach somewhere middle to make it self-sustaining. And you can include lifestyle modifications also now, because now we are afflicted with those. And you already mentioned multi and cross-disciplinary collaborations with UID. I mean, there are too many questions. We can talk later. Thank you.
Thank you for the suggestions. We are a work in progress, so we keep trying to address more and more things. We are already in the north, as I said, in Bihar and Himachal. So we would love to expand to other geographies also. Thank you.
Thank you, Dr. Manoj. It was an interesting presentation. Having lived in parallel universes and traveled similar journeys and not having met and talked is strange. But my struggle at a point in my life cycle is that I'm getting old. Right? I have a similar process. I don't have a second generation leadership which will sustain this process. We do not have alliances, and we do not have Abhisheks who will be influenced. We have psychiatrists who will come and go in 3 months, and who would work in Bhatinda in a substitution therapy center and be paid 4 lakhs a month, or 5 lakhs. And you know, where in substitution centers in Punjab, if you're seeing 100 people and only doing substitution therapy, loneliness will arise. So I think we need to work on alliances away from the auditoria of social psychiatry conference. I think sometimes institutionalizing social psychiatry in this form actually takes you away from the community, because the community does not have a space in this room. And if you're talking about participation and inclusion, the sustenance of knowledge and the sustenance of practice also needs to belong to the community. And I think what you talked about, the wider context of the policy and law, and influencing that is extremely important, because civil society by itself cannot change what is happening in the society. Civil society experiences it, has a narrative around it. So my question to you is, what is your succession plan and what is your sustainability plan?
Thank you very much. I agree with all the points that you have elucidated. I showed my family there. This has been an issue personally troubling me. Now it has begun to trouble people who fund us also, because people have begun to ask, okay, all this is good, but what about after you? So I'm very happy to share that I have managed to find the person will, who is slowly taking over, will take over, much more next year. So I hope to kind of be in the picture, but let someone else lead the organization in better ways than I have been able to. What you said is very, very true. Even, I mean, paradoxically, we are getting more psychiatrists to work with us, but like you said, it's for short terms before they move on to something more attractive. And that is because of the kind of glut in the production of psychiatrists, at least in Kerala. Previously, nobody would want to work with us. But now that has changed, and one of those people kind of has internalized this model and these values, and will be taking over from me. So that has just recently happened. So even my colleagues are not aware of it. So, but since you specifically asked, I
Even snowball the concept, train 5 others, they train 5 others, till you reach the
Yeah.
pan India.
yeah. I mean, all that is, yeah, of course. But to get young psychiatrists who, by the time they finish their MBBS and psychiatry, they are set into a certain pattern of thinking, and social psychiatry doesn't come into it, community psychiatry doesn't, or maybe slightly, but social psychiatry, no. And they are all, they all want to work in prestigious medical colleges, in the government sector, or in the private sector in the best known places. But that has slowly changed, so that at least we are able to have people. Some of them leave fairly soon, like you said, but at least few are beginning to think of this as their long-term future. So it is possible, I feel.
Thank you. Thank you, Dr. Manoj. Now we have time for 2 quick questions. Dr. Srivastu, and then there's last question from there.
Very briefly, I must congratulate you, one, and I identify since I'm also a Shokafia. But my question is away from you, little broader. Are, as psychiatrists, we pushed in the community to do something which governments have not done? And if we are doing such an important work, why the educational system and health system in the government are not recognizing it? Even MD course, despite you having 120 centers, would not send a resident for a training for 3 months to help you. Do we find that majority of us are very insensitive to get involved, or we are overburdened? Last, there is no legal protection of the kind of work that we do. And I must remind that it is extremely important to be legally protected. We only don't realize until that day we face it. So your comments.
Thank you very much, Dr. Srivastu, for that reflection. And okay, the last question, and then we'll bring the session to a close. Thank you.
Good afternoon. Thank you so much for such an inspiring presentation. I am a law professor, not a real doctor like everybody over here, academic doctor, so my perspective might be very different. My take from the presentation will be very different. Sir, since you are catering to the needs of a large community, do you witness conflict with law? Do you witness people violating law? And since you are maintaining such a large database, as mentioned, is that database utilized by law enforcement agencies, including police or advocates for these people, so that we can signify somewhere that they are already receiving mental health treatment, and probably accordingly they should be provided protections within legal frameworks? Because I think that can be another very significant dimension of this work. I would love to hear your thoughts on it. Thank you.
Can I respond? So I'll respond to this question first. Of course, we do not share our database with anybody, but we also find that there is very little conflict with the law in terms of, our work. Often what happens is that, and usually it's a person with, say, in diagnostic terms, with going through an episode of mania, who because of the symptoms of the mental illness gets into problems. And our interventions are at the local level. So we may get a phone call from the sub-inspector of the police through our local partner. And the issue is kind of resolved. We, again, illicit drug use doesn't come into our work in a big way. Of course, there are people with substance abuse issues, but conflict with the law is very infrequent. Mental Health Act doesn't come into it at all. Things are sorted out at the local level, and that is how it has been so far. I think you must understand that these are the poorest sections of the population in whichever state we serve. So they are often quite under the radar for a lot of things. Things like advanced directives and all make no sense in our settings. That's totally not a preoccupation of our people. Sir's questions, I think the way the two systems have always worked in parallel is partly also because as a body of psychiatrists, we do not, like Professor Murthy, I think, Professor Mohanasek said, compared it with the IPS conferences. This is a small group in a small setting where we all believe in this. As a larger body of psychiatrists in India, have we ever put this position to the government that this is how mental health care delivery should be? I don't think we would have. So this is remaining a kind of small academic interest for many of us. For some of us, it's a clinical interest also. But as a body, what does the government do? They listen to professional bodies. So unless, as a group of people, we started believing in this and then put it to governments, I don't think anything will change.
Thank you, Manoj. So there is definitely a need to broaden this from Social Psychiatry Association to the IPS. We don't have any.
We work with survivors of human trafficking, and we work with survivors of domestic violence and sexual abuse. So conflict with law, not by the person living with mental illness, but survivors of violence and abuse do bring us an interface with law. I think if you're working in the community, you cannot move away from the reality of the community, and there are multiple communities. So there can't be one model for India. There can't be a singular way of addressing it. Actually, our greatest partnership comes from law departments and judiciary. Most of my trainings last year were of police officers and judges in Delhi.
Thank you for that reflection, Dr. Bhagat. We'll have to stop the. Yes, definitely. Thank you, Dr. Manoj, and that speaks volumes. I would now like to request
I think there is a
Dr. Isaac to bring.
There is a first time for everything. This is
We will close.
probably this is the only time when I get a standing
Debashish
ovation.
and Nitin were here, eyeballing me. I told Neeraj we have to stop, but he told me that we started 5 minutes late from the previous session. We have taken another 5 minutes. Thank you very much. Thank you, Manoj. Thank you all the participants in the discussion. We could have gone on, but we have another session. Thank you very much.